Welcome to the LACNETS podcast. I'm your host, Lisa Yen. I'm the LACNETS program director, as well as a caregiver and advocate for my husband who is living with NET. In each podcast episode, we talk to a NET expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. Welcome, everyone. It's great to have you on our LACNETS podcast, and we want to welcome Dr. Randy Hecht, who is our guest for today. So before we get started, I thought I'd introduce our special guest for today, Dr. Randy Hecht, who runs the GI Oncology Program at UCLA and is the medical director of the Neuroendocrine tumor program. He is very dedicated to clinical research and to patient care. And I just wanted to add that Dr. Hecht and I have a personal connection, and I've known him over the last about 7 years as my husband and I together have been seeing him for his own personal care as well in this journey with neuroendocrine tumor. So we're really excited to have you here today with us, Dr. Hecht. If you don't mind just introducing yourself and tell us a little bit about how you got into the neuroendocrine tumor world.
Well, thank you so much, and for sharing and asking me. You all do such wonderful work, and the idea that our conversation today can reach and hopefully help many people around the globe is really truly amazing. And so I want to start with I really appreciate everything that LACNETS has done. So I'm actually originally a gastroenterologist before I became a medical oncologist, but I've always been interested in GI cancers. And I'm lucky to be at a place like UCLA where I work with people who really are wonderful physicians in many different groups. So that includes our surgical colleagues, our pathology colleagues, our radiology colleagues, and also our nuclear medicine colleagues. And being able to work with all of them really is part of what interested me in neuroendocrine tumors, because really you need that entire village in order to take care of appropriately and to treat patients who have neuroendocrine tumors. Also, the patients tend to be extremely nice, which is also true. But and you get to have personal relationships with them, which is another thing that I really enjoy. It's also, while we've significantly improved how we take care of patients with neuroendocrine tumors over the period of time and I have gray hair for those of you who are on the podcast, and so that over the period of time I've been taking care of patients, that there's clearly an unmet need, and there's a lot more that we need to do. And it's something that all of us, not just at UCLA, but all of us in the field are working really hard for.
Thank you for that, and for really stepping up and to meet that unmet need. And we know that you created the multidisciplinary NET team and NET tumor board there, and you've really spearheaded that effort. So thank you for all you do.
Oh, you're welcome.
So with that, let's get started with our 10 questions for today, if that's okay with you. Ready?
Once again, I'm ready to go, raring to go.
Okay, our first question for today is, do all NET patients need to be on lanreotide or octreotide? And also, if you would clarify, what's the difference between the two?
So if you step back, what we know is that neuroendocrine tumors almost all of them come from neuroendocrine cells, and they're an awful lot like them. And what happens is that normal neuroendocrine cells are cells that make hormones. And these hormones mostly, not all, but mostly help coordinate things like digestion. And the way that it works is that the normal neuroendocrine cell makes a hormone, and it affects another cell to do something. And once again, endocrine just means hormonal. And then that normal cell makes a turn-off hormone, which is called somatostatin. And in order for somatostatin to have an effect on the neuroendocrine cell, that there are neuroendocrine receptors. And there are at least 5 different classes if you really want to get complicated. But basically, it acts almost like a satellite dish where there's a signal coming in. And usually that signal is to turn off making those hormones. And it almost works kind of like a thermostat where something is done, and then there's somatostatin receptors. And over 90% of low to intermediate grade neuroendocrine tumors also have somatostatin receptors. And we can leverage that a number of different ways. And we can leverage it, one, by giving what are longer acting versions of that natural turnoff hormone, of which octreotide and lanreotide are two. They're the two that tend to be used in neuroendocrine tumors. There are others that are used for other reasons. And that natural turnoff hormone only lasts for minutes. And that's what you would want in the body. But if you're trying to turn off a cell all the time, you don't want to be in the original trials, people were walking around with IV poles. And so instead and it was saving people's lives, but instead, first they came up with injections that you would give several times a day. And now we have long-acting versions that just require an injection once every 4 weeks or so. And what those do is that those basically signal through those somatostatin receptors. They're called somatostatin analogs, or SSAs. Sometimes you'll hear for people who say this a lot. And what happens is that they turn off those cells, and they can turn it off a number of different ways. They can turn off the hormones, if that's a problem, that are made. And it can also, and this came out later, is it can stop those cells from growing. So that's one way we use the fact that almost all low to intermediate grade neuroendocrine tumors have somatostatin receptors. And we can also use those, and we can talk later, for imaging, like in dotatate scans, which also are basically radioactive versions of this. And we can also use this for treatment. We'll talk about PRRT, if that hasn't already been talked about on the podcast, a way to actually kill these neuroendocrine tumor cells. But all of it takes advantage of the fact that almost all neuroendocrine cells have somatostatin receptors. So the two drugs that are used for the treatment, the first one was called octreotide, and that's basically an artificial long-acting version of somatostatin. And lanreotide came out a little bit later, and once again, it's a long-acting version. And both of them have been shown to have activity in effect, tickling the somatostatin receptors to turn off hormones. And so in some patients who have neuroendocrine tumors, have functional tumors. If they're carcinoids, they can have carcinoid syndrome, and these drugs are very effective in turning those hormones off. If they have pancreatic neuroendocrine tumors, some of them are functional and can have hormonal symptoms. And once again, these are very effective in turning those off. Even in patients who don't have hormonal symptoms, there are now trials to show that both of them will help keep the tumors from growing. They don't make the tumors shrink that much, so they can. It's uncommon for them. A better way to say it is it's uncommon for them to make them shrink, but they definitely can stop them from growing. And the question also is one versus the other. I'm not aware of any true head-to-head comparison. They are a little bit different. One is that the octreotide, which is also called sandostatin, is injected a little bit deeper, while the lanreotide or somatulene, which is theoretically deep sub-Q, depending on the build of the patient. And I'm not certain they actually go exactly where we think they go. Some people just seem to like one better than the other. There are also some people will feel that they have more side effects with one rather than the other. I think there's less data from an anti-cancer standpoint about switching from one to another. There are things in the pipeline that are beyond this. For example, there are versions of somatostatin receptors that are not deep sub-Q, but are sub-Q alone. And there are already, for other tumors, actually oral versions that block this that are being looked at. So while these are helpful, they are incredibly helpful for those patients who have hormonal symptoms. They also are really incredibly helpful for stopping tumors from growing. I think that there's still a lot more to be done because nobody likes getting shots every 4 weeks. And I think that particularly if we can get to the oral drugs, I think that will be a definite, improvement for our patients.
Thank you for that really thorough answer and really explanation of what's out there on the landscape and what we have to look forward to as well. Okay. And our next question, how do I know what treatments I should be on?
Boy, that's a tough question. And so, and the answer is, it's an easy answer actually, though. It depends. One of the things that's really interesting about neuroendocrine tumors, and also very difficult about neuroendocrine tumors, is that there's so many different situations. For example, there are patients who can have their tumors completely resected. Okay, that's very different than someone who has tumors that cannot be cut out. Patients who have hormonal symptoms, as we were talking about, may have different treatments than patients who don't. Depending on if it's spread, where it has spread to may have different treatments. For example, patients who have liver dominant or liver only may be eligible for liver directed therapies, while people who have treatments in other parts of their body may not. So I think that probably the best thing is to talk to your doctor. So the first thing that I would ask your doctor is, how many neuroendocrine tumor patients do you take care of? And I cheat because we get them referred in. So obviously I'm saying this because I feel that patients are better taken care of by someone who treats a reasonable number of neuroendocrine. You don't have to only do neuroendocrine tumors, but you have to treat a reasonable number of them. The other thing is that as Lisa was pointing out earlier, is that it really does take a team to best treat patients. And so for some patients, surgery is the best thing. Some patients, medical treatment is the best thing. Some patients, combinations of things are the best things, working with our interventional radiologists. Sometimes patients have unusual tumors, and working with our pathologists are really important. So what I would say is that there is no one size fits all, and that's good. And so, but what you really need is to talk to a group of physicians. You really don't have one physician. You have one physician who is your quarterback, who is backed up by an entire team, and then they can talk and decide what's best. Didn't really answer your question because there is not one answer to that.
That's helpful. I mean, really, as you said, it really depends. And getting to see a net expert with a whole multidisciplinary team is important.
And to be fair, that not every situation has a large randomized trial, the highest level of evidence. So a lot of what we're doing is working with somewhat incomplete data. Now, there are national and international guidelines. For example, NANETS has guidelines. That's the North American Neuroendocrine Tumor Society. The European ENETS has guidelines. There's even the Commonwealth one. There's also NCCN, which is a group of large cancer centers around the country that has guidelines on all sorts of different types of tumors. But once again, it's not a cookbook. It's not one size fits all, but they're often very helpful.
So hopefully then the team with the quarterback that you or the patient is interfacing
It is football
with.
season, yes. So we can talk about quarterbacks, yes. And
so then they will help tailor the treatment for each individual.
Right. It is definitely not one size fits all.
Okay. Well, thank you for that. That's helpful. The third question is, my doctor has recommended I take Everolimus or Afinitor versus Captem. What is the difference between the two? Everolimus, Afinitor versus Captem, and how would I make that decision?
Both of those are medicines. And so that's first, because remember I said there are a bunch of different ways that we treat neuroendocrine tumors, surgery, radiation, blocking off the blood supply. And both of them are actually, all of them are oral. So Everolimus or Afinitor or RAD001, we tend to use the generic names just so that you know, though there is no generic of this, blocks a specific pathway, which is called the mTOR pathway, and is active in a number of different cancers. And that pathway is a signal to grow. And in fact, it's hijacking a normal signal to grow. And there are a number of different drugs that block this. In fact, these are derived from a fungus that was found from an organism that was found on Easter Island. And so these drugs, and they have some activity in neuroendocrine tumors. And in fact, there are randomized trials with Everolimus in both carcinoids as well as pancreatic neuroendocrine tumors. While we often sort of put nets together, that there are clearly differences between them. And we tend to say, well, what cells did they come from? Was it from the pancreas? Did they come from other parts of the body, like the GI tract? Less commonly, did they come from the lung or other, even rarer parts, rather rare neuroendocrine tumors? But there are commonalities, but there are also some differences. And so while both GI neuroendocrine, actually most neuroendocrine tumors will have some benefit from Everolimus, and we were part of they were called the Radiant trials, that there does seem to be some difference. Now, Captem or Captem is a combination of two older generic chemotherapy drugs. And capecitabine is used in many different types of cancers, particularly GI cancers. Those are pills. The other name you'll hear is Xeloda with an X, because X's always sound cooler. And so when you do that, and these are that's also well tolerated, and drugs that we use in frail elderly patients, in fact. It's combined with another drug, which is called temozolomide, which is FDA approved for brain cancers. And a number of groups have shown that the combination of those two had significant activity in neuroendocrine tumors. Now, this is where the difference between where the neuroendocrine tumor came from. While there's some smaller trials that show that patients who have carcinoids or GI neuroendocrine tumors have activity, particularly grade 1, grade 2, but basically neuroendocrine tumors tend to be very slow growing tumors, and which is a really good thing. And so the way that we grade them is not just where they came from, so that's one thing that we do, but also how rapidly they're dividing. And the ways that we can do that is by looking under a pathologist, not me, but a pathologist, someone who does this for a living, looks under the microscope. And you can go back to your high school biology and look at the number of mitoses or dividing cells. Or there's an easier way, which is just there's a stain called Ki67 or Ki, some people say Ki67, I say Ki67, potato. And that marks, basically stains dividing cells. And we use somewhat arbitrary cut points, but many have very few, and those are grade 1. Some have more, but less than 20% of Ki67, and those are grade 2. Patients whose neuroendocrine tumors have greater than 20% are grade 3, and really not as big a difference between grade 1 and grade 2. Grade 3 actually is divided into two different groups, because we used to say, oh, grade 3 is high grade, but it turns out that there are patients who have grade 3 neuroendocrine tumors that act a lot more like grade 1 and grade 2 and are biologically much more like those. And to be honest, someone whose Ki67 is 21% probably their tumor acts a lot more like someone whose Ki67 is 2% than they do with someone whose Ki67 is 90%. And so they're different groups. There are ones that are called well-differentiated, meaning they look more like normal cells and have relatively lower Ki67s, usually under 55%. And those patients act an awful lot like the grade 1 and grade 2. Then there are ones that are called poorly differentiated, meaning they don't look like the cells they came from. And sometimes those are called small cell or large cell, depending where they look under the microscope. They often have very high Ki67s. They're a different beast. And they're really biologically different, genetically different. And for example, they're much more likely to respond to chemotherapy. So, but anyway, back to what I was saying, they're actually a little bit more likely to respond, for example, to CAPE-10. People have higher Ki67s. But let's go back to the majority of our patients who have grade 1 or grade 2. We'll just say low to intermediate grade. And if you divide not just by grade, but where they came from, and this is biology talking, is that patients who have pancreatic low to intermediate grade neuroendocrine tumors actually have a reasonable response to, meaning tumor shrinkage or tumor not growing, to capecitabine and temozolomide or CAP-10 or CAPE-10. Well, I think that if you look at the data, patients whose neuroendocrine tumors are from outside of their GI tract, outside the pancreas, have a pretty low chance of benefiting. And we argue about this, but I think the data looks best. And in fact, the best data was from Pam Kuntz's trial, from the ECOG Akron trial, where the response rates were pretty high for either temozolomide or CAPE-10, and around 30% of patients had responses. And let me define the term response, because my definition of response as an oncologist may not be the same as your definition of a response as a patient. So that we try to just define things so we're all talking the same language. So when you're in oncology, by response, we mean a major shrinkage, where the tumor has shrunk in 3 dimensions by significantly less than half the original volume. Okay, that's not the same as benefiting our patients. So what we say is that, we throw the words response rate out. If someone's tumor shrinks a little bit and they stay that way for a long time, or even if someone's tumor doesn't shrink at all, but they stay that way in good shape for a long time, that's sometimes called clinical benefit. But a lot of patients with pancreatic neuroendocrine tumors actually benefit from the combination of capecitabine and everolimus And I would say, if you asked my opinion, that I think that's a much more active regimen than everolimus. Not that everolimus is not useful, but if I had my, there may be other reasons why an oncologist would choose one or the other, but the major shrinkage rate with everolimus is kind of low single digits. And I think the amount of time spent on therapy is on average lower. Now that being said, it varies from patient to patient. I think back to a patient of mine who had actually a gastronoma, functional neuroendocrine tumor patient, and he was on some of the original trials. And eventually we had to take him off because he'd been on so long, the drug was already approved, and they had to finally say, guys, we have to sort of like, it's closing time. We have to turn off the lights to the trial, but you can get the drug commercially. So this person was on for more than 5 years, but that's uncommon. Was that a really long answer to a short question?
That was a really complicated question. So that was really helpful as you helped us understand how you weigh those decisions. And let me throw out another one that's similar but different. My doctor has recommended I take everolimus.
There are also many ways to pronounce that.
Everolimus or Afinitor versus PRRT. How would I go about making that decision?
Okay. The problem is that none of these have been compared head to head, which is really the best thing. So the way I like to think about it is these are all tools that your oncologist and his or her team have in their back pocket. And so, for example, the most patients who have metastatic neuroendocrine tumors end up on a somatostatin analog for a number of reasons. One, because often, though not always, they're slow growing. Two, in general, the side effects, other than being literally a pain in the butt, that these drugs are generally well tolerated. So the question then comes, well, what happens if these stop working? And, the trials have really not been done to compare different options, but the trials were generally done in patients where a somatostatin analog like octreotide or lanreotide has stopped working. So what I would say is that everolimus has been shown, as I mentioned, both in pancreatic and other GI neuroendocrine tumors, and now more recently in other tumors, to have some benefit. And that on average, it takes longer for their tumor to grow than placebo. Okay. Now, PRRT, let's go back to what I was talking about earlier. Remember, most neuroendocrine tumors have somatostatin receptors. And the question is, well, Dr. Hecht, how can you tell? Well, one is statistically, most do. But remember, we can use them for imaging as well. So you'll hear, back a long time ago, there were called octreotide scans, which hopefully no one is ever using again, but you'll sometimes occasionally see. But instead, we have what are called dotatate scans. And dotatate scans are basically octreotide where you've put a radioactive tag on it. And it can be gallium-68, or it can be, more recently, we have scans which are copper-64. And the gallium-68 is called NetSpot, and the copper-64 is called DetectNet, which we do at UCLA, though I think, and UCSF, it's now beginning to spread around the country. I don't think there are huge differences between them. And what those are basically, you inject those, and it has that tag, and it goes to cells that have somatostatin receptors on them. And using a special camera, they can say, well, one, does your tumor have those receptors? So it's a functional way of looking at it. And second of all, where is it? And in fact, we found that a lot of people had spots of tumor in places we weren't really looking for, that didn't show up on a standard CT or an MRI. And these are types of PET scans, but they're not the type of PET scan that most people get for tumors. Those are radioactive sugar, or FDG. These are very specific ways of looking to see whether your tumor has the receptors. And if it does, then you would be a candidate. And I'm not saying you have to have it right now, but you would be a candidate for what's called PRRT. So PRRT stands for peptide receptor radiotherapy. Okay, but that's too long to say, so we say PRRT. And this has been done for decades with various hotter versions of the radioactive that radioactive tag. And what I say is I call it the sriracha version, because it's hot enough to actually kill the cells that it goes to. And a long time ago, they used other isotopes. We tend to use one which is called lutetium-177. And more recently, they've actually done the right thing, which is to treat it like a drug. because as an oncologist, I care, does it make people live longer and feel better? And they finally did a trial, which was the NETTER-1 trial. And the brand name for this is Lutathera, which you'll see, which is the lutetium-177 as the spice, as the sriracha part. And that is FDA approved and has been shown to actually take a long time for the tumors to grow. It's harder to show overall survival because a lot of the patients who didn't get it initially ended up getting PRRT later, but it looks like patients probably live longer. And those are the things I care about. So then that would be another option. We don't know exactly when to use it because you can only use it for so long or so many times. That's a better way of saying it. And so normally PRRT it's been done a number of different ways, but the standard way is to give it once every 2 months for 4 times, for 4 treatments. You don't get really any treatment except for your octreotide or lanreotide in between. And the median, meaning the person in the middle time before the tumor gets worse, is generally between 2 and 3 years, with not everyone benefits and some people going significantly longer. So that is one of the things that we can do. And the question is where to fit that in. And the answer is, I tend to do it earlier rather than later, but I would be the first person to say that those studies have not been done. There may be other reasons why you would choose one or the other, getting a little bit inside baseball. Oh, baseball season's over, but anyway, I tend to do it earlier rather than later. But there's some people who say, no, I'd rather take pills, or it's hard for me to come in, and so there is no right answer for that. But if you were with me, I would say I tend to use it a little bit earlier. The other reason is that sort of plays into the calculus of this is that you can only do it so many times. And so as I said, you can be on Everolimus for years, though most people aren't, unfortunately. But there's mostly European data that after you do that, if the tumor does start growing, again, you can give salvage, and you can even give salvage again. There is no theoretical upper limit, but generally it's been uncommon to give more than 8 sort of doses or cycles of this. And if I have patients who have very slow growing tumors, for example, who are really young, I may want to save that for later. If I have someone whose tumor I think is growing a little bit faster, or I feel I need a response, I may use that earlier. As I mentioned a little bit before, I would say that pancreatic neuroendocrine tumors have a few more arrows in their quiver than carcinoids. So for carcinoids, for example, I have fewer options. Once again, a long answer. I apologize.
Yeah. This is really helpful. And I know you and I have had many of these types of discussions about treatment decisions before. And I just wanted to kind of follow up on one statement that you made, which is that you tend to use it earlier rather than later. And if you remember back, a lot of people used to, try to keep it in their back pocket and use it last. So what makes you say you would use it earlier?
Well, one thing is that, remember, there was when PRRT was finally approved, which meant the key thing was it was paid for, because it's very expensive if it's not paid for, as you know. And so really what was keeping it being done in the United States was not that it couldn't be done, it just wasn't paid for by insurance because it wasn't approved, because it was done kind of locally. So what happened was, once it was approved, we had all these patients who had had multiple treatments before but had been waiting to get PRRT, so they were getting it in their 3rd treatment, or their 3rd anti-cancer treatment, or their 4th or their 5th. Well, now once those patients were sort of out of the way, the question came up, which you just said. So there isn't a right answer. And in fact, if you go to our guidelines, they list a number of different options. And so this is what the oncologist, really should talk to you as the patient. At the end of the day, the patient's the boss. And so our job is to help make suggestions and to lead them and to educate. But as I said, I think that someone who had very slow growing cancer, for example, or neuroendocrine tumor, then you may want to wait a little bit and try other things. For example, NETTER-1, if you look, actually used a higher dose of octreotide. And there's European data that I don't think it was a placebo. I think it had activity. And it's something that we do. If someone, Everolimus, and so as I said, Cape-10 is something that you can, something you can do. For my younger patients, I tend to save it a little bit. But if I have someone who I feel that the tumor is growing more rapidly, or there's enough tumor that it's causing problems and I feel like I need a response, I'm more likely to use it earlier. But in the average patient, and my average patient tends to be a little bit older, though I have patients in their 30s, 20s, and 30s, in the average patient, I tend to use it after patients have clearly progressed on a somatostatin analog like lanreotide or octreotide.
Okay, thanks for that. So that sounds
Sure.
like second line for you. Okay, so this
Frequently.
this is a good timing for this next question. So once I have had PRRT, what do I do next if the tumor progresses?
That's a really interesting question. And so some of it depends on whether or not it's where the tumor came from. For example, if it's a pancreatic neuroendocrine tumor, I think capecitabine and temozolomide is a very reasonable thing to do. I just don't think that's a great option. Some of it may also depend on what the grade of the tumor is. And so that the higher the Ki-67, the more likely you are to respond to chemotherapy. For example, someone who has a tumor with a Ki-67 of 20%, and sometimes over time, it does tend to go up a little bit. It doesn't go from 2 to 90, but it can go from, 8, and then if you had a liver biopsy a number of years later, it might be 23% or something. And so those patients may benefit from chemotherapy, different types, even carcinoid patients. The other thing is that there is salvage PRRT. And so now that has been looked at mostly in Europe because, as I said, it's been available, meaning it's being paid for a lot longer. And usually what happens in salvage PRRT is that rather than giving the 4 doses that we would normally give, is that we usually give 2 doses. And that's more because of side effects, because the main side effects that we would see as if you give too much tend to be having to do with the blood counts. But I can't say that there's ever been trials to show that 2 is different than 1 versus higher number. And if you look at the European data, patients who've had a good response to PRRT, and in particular who have gone a long time before the tumor got worse, are more likely to benefit. I think patients who have pancreatic neuroendocrine tumors are also more likely to benefit and these cut points are arbitrary. They're not necessarily evidence-based, but at UCLA, if someone's tumor has gotten worse within a year after they started, they're probably not going to benefit as much, or less likely to benefit from salvage PRRT, and I'd be looking for something else. The other question that sort of comes up as interesting is that even patients where the PRRT has stopped working, we're following these patients with functional imaging, meaning like a NET spot or detect NET, a gallium-68 or copper-64 dotatate, but they still maintain their positivity most of the time, which is interesting because one would think that you might lose that because you're killing the cells but most patients who were dotatate positive at the beginning actually are dotatate positive, even if the tumor does grow eventually.
Yeah, this is all very helpful. And as you and I have had many of these discussions before, would you also kind of clarify for the audience what salvage PRRT means? Salvage
just means that it eventually stopped working. And so, as I said, that we tend not to give the full dose. And so that this has been worked out over years, that over decades really, that 2 things. One, that people do benefit. Now, that's not the case for most anti-cancer treatments that you're on all the time. That going back to something that didn't work often in cancer, not 100% of the time, but doesn't work. But I think the reason that salvage, meaning giving it again, does work is because, remember, often patients can go for years, after their last PRRT. And so it's not surprising that, we don't eliminate the cells, that we just kill a lot of them, that eventually some of them grow back and they still have those somatostatin receptors so that you can kill them again.
Okay, thanks for that. So salvage
kind of like like crabgrass.
Salvage is repeating it again. And as you know, that's
all it means. Thank you for correcting. Sometimes I lapse into jargon. I'm always happy when people say, please speak lay.
Okay. So repeating it again, of course, my husband had his first 4 rounds of LU-177 dotatate PRRT, and then he had it again. So that's salvage PRRT. Okay.
Exactly.
Just to
And
clarify.
so, and right, it's just a fancy way of saying, I think it's mostly to say that we're not doing it for the first time. You
Not
could
to,
make up other names, repeat, doing it again, but
okay,
it's just, yeah.
that's helpful. That's helpful. And, of course, everyone's curious. How do I find out what new treatments are on the horizon for NET?
Well, I think there are a couple different ways. One is, of course, your doctor, and hopefully is the person who's been keeping up with this. But, they're extraordinarily human and certainly don't know everything. And one thing I would have to say is that if you're listening to this podcast, that means you are active and you have agency and you're interested and you're interested in your tumor. And while there's huge amount of disinformation, on the internet, fortunately, there are actually very good places to find out information, which of course LACNETS is an extraordinarily good one. Other places that you may find out or would be, other similar groups as well. The other things that you could look at would be, our national organizations like NANETS, and though those tend to be not written in a format that's always patient friendly, as you go to the more you go to people speaking jargon like Salvage among themselves, it sometimes is a little bit harder. What I would say, though, that one nice thing about the neuroendocrine community is it's an extraordinarily collaborative community, both ranging from the I would say starting at the bottom with the physicians and going to the top with the patients, is that if something works well, the word gets out pretty quickly. Now, what I would say is the question is, what's the definition of working well? Because at the end of the day, really what you want is a randomized trial to say that new treatment A is better than new treatment B, or old treatment B. That's a better way of saying it. And so sometimes it's new treatment A is better than nothing if nothing is the right answer in that situation for those trials. Now, what I would say is that most of what we've been seeing, I think I'm going to lead into one of your other questions, is that I would divide new treatments up into two different groups. One are, can we use the approaches that have already been shown to have benefit in neuroendocrine tumors? Are there ways to tweak and adjust those to make them work even better? Okay. And for example, there are other, for PRRT, which we just finished talking about, there are newer ways of trying to basically use the to tweak the somatostatin receptor and to try to use it, for example, using different emitters like alpha emitters, and getting into the weeds, but basically different radioactive isotopes that you can hook onto something that will go to a cell that has somatostatin receptors. And that's been one of the things that there's a lot of research that's going on. There's sort of a kind of a ferment of small companies and large kind of looking at this, but it's basically the same pathway, the same way of doing it, but we know that it works, can we do better? And I think that possibly, but show me the data. And a little bit different than that, but also trying to tweak that. I actually happened to see at NANETS is using something that's been looked at in other cancers, is trying to attach chemotherapy basically instead of radio. And in other cancers, people have been doing both chemotherapy and radioactive isotopes to kill cells. It's historically actually the chemotherapy attached has been more effective, and only more recently in a number of different cancers, like for example in prostate cancer, has it been that the radiation, which was the early front runner, has kind of come roaring back. What I would say is that right now that has not been that successful. There was a small abstract actually out of Emory looking at, as someone who does this in other cancers, I would have to say that it's very warlike. The payload or warhead that they used I don't think is a particularly active one. And I think that there may be more oomph in that, and ways that have been looked at with other cancers and maybe better. So I wouldn't sort of throw that out yet. Other ways that we've been looking at to try to kind of tweak things is that we know that drugs that hit I'm going to define this in a second, the VEGF pathway, which is the vascular endothelial growth factor pathway, which is a pathway that your normal body uses to basically tell the body to grow new blood vessels. And we've known for literally for decades that drugs that block that pathway have at least some activity against neuroendocrine tumors. Antibodies have some modest activity, and one called Avastin or bevacizumab, though that has not been looked at as much recently. We know that there are pills, which are sometimes called small molecule inhibitors. For example, sunitinib is actually approved in pancreatic neuroendocrine tumors. And there are a whole bunch of these. And what they do is that they block this, basically they muck up the signaling. And these are different receptors and different pathways that get turned on to grow new blood vessels. But the problem is that none of these are really that clean, and they probably hit a whole bunch of other pathways. And there are a number of drugs that are out there, and some of them are probably more interesting than others. We know that some FDA-approved ones like pazopanib or sorafenib, and I personally have had patients who have been on them, may get benefit. I don't think those are huge advances, to be honest, over, I think the two that are probably being looked at the most, and I'm not certain I pronounce it correctly, is surufatinib, which is a Chinese drug, has some activity. But I have to be honest, I was a little bit underwhelmed. I didn't think it was clearly that much better. Doesn't mean for an individual patient that it may not. And I know they're going to the FDA to see whether or not that they can get benefit. But if you told me that that was clearly different, if you asked if that data to me, my personal looking at it, and it was some of it was recently published, is clearly different than the drugs that are already around, I'm not so certain. The one I think that has the most interest I find most interesting is a drug that's already FDA approved, which is lenvatinib. And particularly in patients with pancreatic, there's some recent data of patients that was just published with patients with pancreatic neuroendocrine tumors, had a very high response rate, whether it was major shrinkage rate, and also had some benefit in patients who had, carcinoids and GI, other GI neuroendocrine tumors. That's not necessarily the easiest drug in the world. It's used in a number of cancers, particularly liver cancer. Primary liver cancer, meaning it started in the liver cells. But all these are basically saying, can we do better with the pathways that we know about? Now, the other question is, well, okay, as I say, it's kind of like the old story about, the drunk looking for his keys and asked, why is he looking, under the light post? Because that's where I can see. So, we keep going back to these same pathways over and over again. And I'm not saying that it's not useful and that better PRRT will help my patients and better small molecule VEGF inhibitors will help my patients. But the next question is that, well, how can we do better than this? And that's really, I think, what all of us, no one wants to have a small incremental, and even though that helps patients, people want big incremental improvements. And so in some cancers, immunotherapy has been really helpful. And unfortunately, for the vast majority of patients with neuroendocrine tumors, particularly those who have low to intermediate, the vast majority of them, these have been really a bust, I would say. And I think that the things that you see advertised on TV, like Keytruda, which is pembrolizumab, or Opdivo, which is nivolumab, or any of the other 10 or 15 now very similar antibodies that have been looked at, that the benefit in patients who have low to intermediate grade neuroendocrine tumors is slight at best. And we can have a separate podcast as to why that may be. It may be because those tumors actually don't have a lot of mutations, and there's a correlation between number of mutations and clinical benefit. But it just seems that, so all those drugs basically try to get your immune system to identify the tumor as not you, but as something that's foreign, and to kill it. And the problem is that there's those, at least those, not that that's impossible, have not been particularly helpful. And clearly there are other things that we need to do to get your immune system to recognize that. Now, high-grade neuroendocrine tumors, which those patients unfortunately tend to do worse. They're more likely to respond to chemotherapy, but it tends not to last that long, unfortunately. There is some data that the combination of two immunotherapies, nivolumab plus another one called ipilimumab, which has the terrible brand name of Yervoy. And that combination they're running out of easy names, and you can't do one that says cancer be gone or something. So it has to be something that hasn't been used yet. And that combination is interesting, though the numbers are small. And in fact, at the net, we were just talking about NANETs. There were a number of actually disappointing single aid, I think, trials or very small studies of looking at chemotherapy plus an immunotherapy or single agent immunotherapies in high grade. And so I would say that, if you asked where I think the most interesting thing would be trying to, from an immunotherapy standpoint. And what I would say is that because immunotherapies have helped in some cancers, there are lots of different immunotherapy trials out there. And I would say that any patient with a high-grade neuroendocrine tumor in particular, or who wants to do something else, that a novel immunotherapy trial would be very, very reasonable for them. And so I think those patients are great candidates because we only have so many things that we can do, and we're trying to get that going. The other place that I think we need to know more about is that we treat all these patients the same. If you've noticed that how I divvy patients up could have been done 150 years ago by a pathologist, because, count how many cells are dividing and what organ did they come from. And clearly we would like to know which patients are going to benefit from which therapy, and are there patients who might benefit from therapies that we're not thinking about? Are there pathways that we can block? We know that blocking VEGF helps patients. We know blocking somatostatin receptors helps patients. And I think that there are lots of groups that are looking at this. It hasn't really borne fruit yet. The one thing that I would say, I think it's reasonable, particularly for high-grade neuroendocrine tumors, to do something called next-generation sequencing, which looks at about 600 different genes. And most of the time you don't find what's called an actionable mutation, something that would tell you to do something different than you would do already. But occasionally you do. And those patients may have different treatments that are not in what we just talked about. And I think from a research standpoint, the genomics revolution, as it gets cheaper and cheaper, in order to not just look at 600 different genes, but the entire exome, which is all the ones that are turned into proteins, or the whole genome, may lead to new treatments in the future. But as a clinical trialist, that's what I do. Also, in addition to taking care of patients, it's harder to do trials in 1% of a relatively uncommon tumor. And so we're still trying to figure out how to do that. So back to your question is that I think we're going to do what we're doing now better, and that will help patients. And we're desperately looking for new things, not just the same old stuff, to help our patients.
Thank you for that. I mean, you're such a wealth of information. Thanks for giving us this overview, right? Of all that.
Hopefully it wasn't too much. And so I'm always happy to talk to people. And this is why it's really important for you to talk to your physicians, because if they can't explain it to you, then they don't understand it that well.
Yeah. Okay.
And many of my patients understand things better than I do. Many of my patients with neuroendocrine tumors, as you know, are extraordinarily well-read and bright.
They are very empowered. So I guess the next question that kind of comes up around that area of looking forward to the future and what's on the horizon is, would there be any treatments that negate future choices of treatment options or clinical trials? So I should be aware of this in that sequencing.
That's actually a really good question. So I'm going to take that in two separate parts. One, are there treatments that I can get today that will mess up treatments I can get tomorrow that are already approved? And the other, I'm going to put the other one a little bit to the side. And what I would say is not clearly, okay, but theoretically. So the one treatment that we haven't talked as much about, or I think I just talked a little bit about, was liver-directed therapies. And liver-directed therapies have been around for a long time. And there are patients who benefit from liver-directed therapies. And in fact, I would say neuroendocrine tumor patients probably benefit from liver-directed therapies more than just about any other cancer, because one, that's often the only or dominant place where it goes. Two, because it tends to be slow growing, you get to have the advantage of, so if someone has a different type of tumor, let's say pancreatic carcinoma, well, cutting it out or destroying it in the liver doesn't really help a lot when it comes back in 5 different other places. But neuroendocrine tumors, those can be very helpful. And the problem is, because these are procedures, it's been very difficult to compare them against drugs. Remember, PRRT was finally treated like a drug, and they said, do people live longer and feel better, which is what you care about, as opposed to, yes, we can do this. So it's been harder to do that. Now, there are a couple different ways that people do liver-directed therapies. One, of course, is surgery. That's kind of the original liver-directed therapy. The liver is also amazing in that you can cut out or destroy 2/3 of the liver, and it will grow back in a relatively short period of time, measured in weeks. There are not many other organs, or if I say, there aren't any other organs that really do that. So we sometimes will block off the blood supply to neuroendocrine tumors because they tend to actually trick your body into really, really filling it up with blood. And so they're blood vessels that grow to neuroendocrine tumors, and you can block that off. And that's called embolization, by putting a plug in of something to block off the blood supply. You can also put little radioactive beads that go to the little vessels in there, and that's called radioembolization. And usually the isotope that's used is called Y90. So here people call Y90, though Y90 is just the isotope. It can be used for other things. And so there is some thought that people who get a lot of radiation to their liver from radioembolization, there may be some interaction between the two, though it's been really hard to show that in real life. And so if you're asking what would be the other possible interaction, would be that some chemotherapy drugs can also suppress the bone marrow, of which temozolomide is the one that actually has probably the most suppressive. Capecitabine by itself, probably not. Everolimus, and small molecule VEGF inhibitors really don't. Some chemotherapy drugs that we use, in like 5-FU and oxaliplatin a little bit, but really it's the temozolomide that probably, and other similar drugs that we don't tend to use anymore. So there are a couple of ways. If someone's blood counts are low because of temozolomide, it may be harder to give PRRT. Flipping it around the other way, PRRT, especially in a patient who has a lot of bone metastases, remember the blood, including the blood, both the red and the white and the platelets, are made in the bone marrow. So if you radiate that by having radioactive, basically octreotide going to that, it may make it a little bit harder to do that. And then there is a feared complication actually with both of them. Both drugs like temozolomide can rarely cause leukemias, and radiation has PRRT. A less than 1% of people can get leukemias. A little bit higher percentage can get something called myelodysplastic syndrome, which is a pre-leukemic situation. And as we've discussed, the combinations of those two drugs at the same time may be worse, though there's a limited amount of data. And so, but none of those are absolutes. So what I would say is that this is the art of medicine. This is the art of what we do. And that I certainly have had lots of patients who've had both PRRT and capecitabine and temozolomide, but you have to just look and see, really, and see what you're doing. Now, as for trials, what I would say is that right now, there are no trials that are clearly with drugs that are clearly a home run, and trials come and go. So I would not change anything that I'm doing for a potentially future trial.
That's all very helpful, because this is, I know this is a difficult
I would
question.
ask the same questions. Those are all very good questions.
Thank you for this answer. And I'm glad you brought up bone mets. Another question that comes up often is, what does it mean if I have bone mets? Does that mean my prognosis is worse, or does it mean my tumors are getting worse?
Well, it depends. Once again, it depends. I can just like have like a button, and it has a recording of me saying it depends. And so I think it's been looked at a couple different ways. One is that until we did dotatate scans, we probably missed a huge number of bony metastases in patients that were never clinically important. In other words, people had some spots in their bones. We couldn't see it on, you'll hear the term cross-sectional imaging. That means CT or MRI. And they're there. And in the vast majority of patients, they don't cause problems. So I think that really, those patients who have a limited number that we would never have found anyway, I don't think it makes a big difference. If you look at these large series, it probably is worse. But I don't know, does it mean that it's worse just because you have new spots? Or is it worse because there's something specific about the bone? People have sort of argued both ways. What I would say is that some of those studies are older and use older ways of looking for bone metastases. And so I don't think it's a total apples to apples comparison as to someone who has modern dotatate scanning and finds a single small spot in the bone is very different than someone who has lots and lots and lots of spots in the bone. So it doesn't change necessarily what I would do. So the next question is, it doesn't change necessarily what I would do from a anti-neuroendocrine tumor standpoint. Well, I take that back. What I would say is that if you have someone who had just a CT scan and had liver metastases, and that would look like there was all there is, and then they end up getting a dotatate scan and there are a lot of bony metastases, I probably would be more likely to give something that treats the whole body than liver only. That's one way it would change what I'm doing. Patients who have pain from a bony metastasis, that's a completely different animal, and that needs to be taken care of, whether it's by radiating it. Occasionally patients have fractures and need surgery, but the percentages are pretty small. The other place that it has affected what we do is that neuroendocrine tumors are one of the few tumors that actually can get liver transplants. And what I would say is that we used to do more of those. UCLA historically was the largest liver transplant program in the world. We actually certainly transplanted patients who had neuroendocrine tumors before we did dotatate scans, but that's only for people who have nothing outside the liver. Since we're finding patients who have symptoms, who don't have symptoms of bony metastases, and then therefore that would make them ineligible for liver transplant. So I would say we're doing a lot fewer. Also, we have a lot more options instead of liver transplant. So we really aren't doing very many of those anymore, though I still have patients who are alive and doing well who had liver transplants. So the other question, which is something I've been thinking about recently, is, well, what do you do with those bony metastases that are not causing problems? And the answer is we don't know for certain. And so we know that for other cancers, there are drugs that you can take that seem, particularly for breast and prostate and other cancers, that they're drugs that are actually the same drugs we give to mostly women, but people who have osteoporosis. And so there are ones that are called, there's a class of drugs called bisphosphonates, like Zometa, which is the brand name for one of them, or another drug, which is an antibody, which is called denosumab, which is advertised as Prolia in low dose, and we give for patients who have bony metastases is something called Xgeva, same drug, different doses. And the question is, how well do they work in patients with neuroendocrine tumors? And the answer is, we don't really know. So I've gone back to, at least my reading of the literature is they may, but it hasn't been looked at probably as closely as I would like. There is no such thing as a free lunch. Even though these drugs are well tolerated, they do have potential side effects. They're rare side effects where you can something called osteonecrosis of the jaw, and people have had either have had radiation to the jaw or lots of teeth pulled. I have never seen that, thank goodness, but that's a bad one. So I kind of do it, by the seat of my pants, and which is that I think someone who has increasing bony metastases, it's another tool in my toolbox. And someone who has modest number of bony metastases and may have potential reasons not to give it, I don't. And our guidelines are similarly kind of wishy-washy about this, to consider things.
Thank you for that. I think that's a great overview of everything to do with bone mets. And you've given us a lot of information about somatostatin receptors, a really a good understanding of it. So what about people who don't have somatostatin receptors? Should they still have the gallium dotatate scan? And if not, what tests or scans would you recommend?
Okay, so I think there are two things. So one is some places will still, and I've seen it, but uncommon, do staining of the tissue looking for somatostatin receptors. And that's not helpful. Okay, so I have seen people say, well, someone did a stain for some, and there are at least 5 different types of somatostatin receptors. And so the dotatate scan is the best scan from a functional standpoint. So that's really the only thing that we really care about. And the reason is because there are these pairs called theranostic pairs, where basically same drug, either a little bit radioactive so you can detect it on a camera, or very radioactive so it kills cells. But you're right, not everyone on a dotatate scan is positive. And as I said, only about 90%. And what I would say is that, one, we don't know probably biologically enough about these patients as we should. And two, that those patients should not get PRRT. And so what we know is that would be toxicity without benefit. And there are different ways they compare. Interestingly, most of the original PRRT trials were done, I don't know if you remember, like NETTER-1 with an octreotide scan, which is not a very sensitive way of looking at things. And it takes 3 days and it gives you blobs, and it's really hard to read. This is where, to be honest, I would also want my scan to be read by people who read a lot of them. You don't want to be at, some tiny hospital out in the hinterlands. And I know this sounds very elitist, but it really is true. So they're both over and under calling things if they don't do a lot of dotatate scans. And so before I would say that my scan did not show adequate, and they use the liver and the spleen to compare with, it's called a Krenning score. And what I would say is that have it at least overread or redone by a place that does an awful lot of them. The flip side, we've also seen a reasonable number of overcalls, particularly in what's called the uncinate of the pancreas or the knee of the pancreas, where there's just normal neuroendocrine cells there, and people are being told they have a metastasis there. And the answer is no, that's being overread. But so let's go to those 10%. I think that those are patients who unfortunately often are probably not. I think their biology is a little bit different, and that you clearly should not have PRRT. I'm going to flip it a little bit, is that we know that high-grade neuroendocrine tumors generally do not have enough somatostatin receptors to be useful. So it's only about 10%. So it's 90-10, 10-90. It's sort of, though it depends on the trial. So what I would say is that the patients who do actually still, if you're in that minority of patients who are dotatate positive, particularly if it's a well-differentiated grade 3, those patients may benefit. Now, the benefit on average tends to be shorter, but if you're the patient who benefits longer, it's still worth doing. And there's a number of series to show that those patients who are dotatate positive, it's worth doing even if it's a grade 3. They tend to be, this is where it gets confusing, they tend to be FDG PET positive. PET means nuclear medicine. FDG is radioactive sugar, and it goes to rapidly dividing cells. So if 90% of your cells are dividing, those light up. Most of the time it's one or the other, but there are some that are both PET positive and dotatate positive. So it's a useful thing, but my personal feeling is that if you're at a place that doesn't do a lot of them, before someone tells you your dotatate scan, one is your dotatate scan is negative, have it at least looked at or redone at a place that does an awful lot of them. Second is beware of overcalling, particularly in the pancreas.
That's some helpful practical tips.
Mm-hmm.
So you've given us a really great overview of treatments that are currently available and treatments on the horizon in development. So which of these treatments or other developments in this field are you most excited about? And I guess lastly, what hope might you offer for those living with neuroendocrine tumor or their loved ones?
So what I would say would be, I think in the short term, we're much more likely to benefit from the tweaks. And so whether better small molecule VEGF receptor inhibitors or better PRRT, I don't think that there's anything right now that I would say that tomorrow or next year is going to come out of the skies and say, though people should continue to look at. And what we do is we do smaller trials before they do larger trials. And I would definitely, if you're unfortunately in that setting where the standard treatments either have not worked or have stopped working, that phase 1 trials or a small neuroendocrine tumor-directed trial would be reasonable. I would also, if you're at a place that does not have a I know this sounds like a broken record, and just for those that are young, records are things that people used to listen to that had a needle, and anyway, but make certain that you get a second opinion before someone tells you that there aren't other options, because often there are other options, if you squint. Now, for hope, what I would say is that the good news is that neuroendocrine tumors tend to be slow growing, and that's always great news for most patients with grade 1 and grade 2. And what I would also say is that if there is a new treatment, everyone does not have to be helped. This is my doctor hat, which is that the person I care about most right then is the person who's sitting in front of me. And if that patient's helped, that's all that's important. So I would say that I wouldn't do something that helps no one. That's not fair to you. But if there is a chance that something could help you, I would go ahead with it. And I think that the other thing for hope, which is always in it, hope is like so incredibly important, and such an interesting word, is that if you went back 10 years or so, there weren't a lot of people really looking into the treatment or the care of patients with neuroendocrine tumors. What there were is there were a couple isolated places that really had interest in it. And suddenly there's this explosion. And some of it has been the fact that we have active treatments. Some of it has been, I think a large part has been because of the advocacy groups, like LACNets and all the other advocacy groups that are out there, and people and patients and family members pushing and pushing. And so I think that there's a whole generation, if I can rephrase that, I know that there's a whole generation of bright young scientists and physicians and clinical translational people who are working on neuroendocrine tumors when it was felt to not be that interesting 10 or 15 years ago. And I think that generation of scientists, and go with the science, that generation of scientists they're the ones that are going to come up with the new treatments. They're the ones who are going to tell us which treatments to use in which patients. And the fact that, we were talking before we started that both of us attended NANETS virtually. When you look at the posters, all these bright young people in all sorts of different institutions who have decided to do their research in neuroendocrine tumors is a really wonderful thing. And that generation, not necessarily even my generation, but that next generation, those are the ones that I have hope for.
Wow. Thank you so much for all of this. This has been so informational, educational, and hopeful. And we have so much to hope for. Yeah. I mean, in the last 7 years that you and I have known each other, we look to see how much has changed, treatments and developments and the community as a whole. And we have
look
so
at
much.
How NANETS has changed. And so this is for those of you who are not, NANETS is the North American Neuroendocrine Tumor Society. And, it used to be that they would hold meetings in very small conference rooms. And now this is a large meeting that gets larger every year. And it's been powered by the advocacy community, and it's been powered by interest. And whether it's interest from government research, government funded research, the government still does fund a reasonable amount of particularly basic research, or whether it's research from industry. There are companies that are out there specifically to look at and to treat neuroendocrine tumor patients that weren't out there before. So that's just a perfect example of just how things have changed in a relatively short period of time. And that's very hopeful.
That's a really good point, because there's more doctors, more physicians and experts like you who are
more
out
money.
there.
Money is the mother's milk of research. And
Yeah.
there is money out there, whether it's from the advocacy groups or from the government, or whether it's from industry, all funding that research to help patients.
And like you're saying, more healthcare professionals in the room who are interested, willing to do the research, willing to fight and take care of patients and get the word out there and help us to live better lives. That's the bottom line. Thank you so much for all of this. This is so helpful.
You're quite welcome. Thank you very much for inviting me and for all the work that y'all do.
Thank you.
Thanks for listening to the LACNETS podcast. We want to thank our presenting sponsors, Ipsen Pharmaceutical and Advanced Accelerator Applications. For more information about neuroendocrine cancer, go to www.lacnets.org.